My name is Elizabeth Rebo. I'm the Executive Director of Medication Safety at Kaiser Permanente's National Pharmacy Services. Now we're going to get into the applicability of failure mode and effects analysis with a couple of case examples, which I hope will highlight how you can put FMEA into action. I have no financial relationships to disclose as it relates to this presentation. Our learning objective in this part of the module is simple. We want to apply failure mode and effects analysis for risk identification. A good bit of abbreviations in this particular part of the module. Self-assessment question number 1. In the ADC example, which FMEA steps did the team complete? A, describe the process. B, identify what could go wrong during each step of the process. C, pick which problems to work on eliminating. D, A and B. Or E, all of the above. So our first case study, this is going to be something that my organization underwent in the most recent few months. And this is a project that has been ongoing for a couple of years. We just wrapped it up. And so we were able to do FMEA before bringing in the technology, which has helped us identify risk points. And we've actually been able to subsequently mitigate some of the identified pieces, but I will go into this in more detail. But this is a transition in the point of sale tool for outpatient pharmacies. So outpatient pharmacy transitioned from the current point of sale system to one that's called Consumer Payment Experience, or CPX. So you'll hear me refer to it most commonly as CPX. There was a similar workflow process to the previous system, and so there wasn't a good bit of change in regards to workflow and process, and the project was implemented in 2023, excuse me. For some background, literature estimates the error rate of dispensing the wrong medication to a patient at the point of sale is 1.22 per 1,000 prescriptions. We have about 4 billion prescriptions that are filled annually in the United States, so that's around 390,000 prescriptions being dispensed to the wrong patient, or an average of about 7 errors per month per U.S. pharmacy. The most frequent contributing factors are infrequent patient counseling and flawed patient identification. It's estimated that pharmacy staff follow a patient identification process at the point of sale only half the time. So obviously a lot of risk there. At Kaiser Permanente, we wanted to do an external retail pharmacy assessment, and that's what you see here. So as part of our background work for the FMEA, and I will say, I personally was not involved in this FMEA. One of my team members conducted this with a group of SMEs, but this was, I thought, really interesting to understand what do our competitors in the outpatient pharmacy space do as it relates to point of sale, and what learnings could we get possibly from their tools. The most common scenario that was identified as being problematic is the lack of two patient identifiers, and this can be for a variety of different reasons. But one that we honed in on is the wrong MRN, the medical record number being used. So an example of where this could happen and go wrong, pharmacy team member calls a patient to the register, someone else presents, maybe they misunderstood, what have you. A pharmacy team member uses the prescription in hand to look up the MRN, the medical record number, to sell the prescription. And then maybe there's similar names. There's a whole host of things that could go wrong here, but that similar names listed could be a contributing factor with the wrong MRN being used. So you can see where in this process, there's a whole lot of things that can go wrong. A lot of times the patient may not have their insurance card, so we don't have their MRN. So maybe you're trying to use other patient identifiers, or maybe someone just doesn't really worry about using two patient identifiers. And so the prescription gets sold to the wrong person. So for this particular FMEA, what we did is bring together a team of pharmacy operations leaders, frontline employees, and medication safety leaders to conduct a modified FMEA based on the current system and processes. The scope was inclusive of local pharmacy only. So at Kaiser Permanente, we also have a large mail order component, but that was considered out of scope for this particular initiative because this is really only looking at that point of sale, the CPX tool that's being used in the outpatient pharmacies. Additionally, to further narrow the scope, we targeted only the patient identification step as there was currently at Kaiser at the time no national policy or SOP, standard operating procedure, around it. And in looking at our own internal data, this showed us the greatest area of risk in regards to what was reported. I talked in the previous part of the module about the process map, and so I know you probably cannot read this, but just wanted to highlight how important it is to map out the process so that you can understand it. So again, this is just looking at the point of selling a prescription to the patient, but you can see it's a complex process and a lot of steps here. So it's so important that as you're starting your FMEA, to map out the process so that you can understand all the different parts that are occurring. And then, of course, you can then help narrow your scope based on whatever it is that you're trying to assess. But putting together that process map, very, very important. To close out this example, I wanted to provide our FMEA summary that we completed at the end of this particular initiative. It may be a little challenging for you to read, but I wanted it included so that you can understand and see from our perspective how we put this entire work plan and that progress together. You'll see on the left-hand side FMEA information such as what is the system, the component, the function, what is the potential failure mode, the potential effects of the failure mode. You can see our rankings of severity, occurrence, and detection, as well as our potential causes of failure, what our current corrective and prevention action may be. Unfortunately, this example, we did not have any, and then any current controls, and then of course our RPN, which is again calculated from combining and multiplying the severity times the occurrence times the detection. And on the far right-hand side, this is our recommended action, so our action plan. So again, failure modes can take a variety of different shapes and forms. This is what we used in this particular example to be able to have all the information outlined appropriately, easily, so that we can understand where was our biggest risk and what we wanted to do in regards to action about it. The largest failure modes that we identified during this project, the first was that the identification card is not requested by the pharmacy employee, and the second is that the identification card is not presented by the member or caregiver. This is important specifically at Kaiser Permanente. The identification card that we use for our health plan has all of the pertinent patient information that we would need to be able to ensure that we are dispensing the prescription to the appropriate person. It has information such as the patient's MRN, the medical record number, their name, date of birth, all the different identifying properties that you would use whenever you are doing two patient identifiers to be able to, again, identify that you are providing the prescription to the right person. Another failure mode we identified throughout this project is that the second form of patient identification was not being requested by the pharmacy employee. So this could be in lieu of someone who does not have their identification card. Not everyone keeps that in their wallet or in their purse. And so in those instances, what we do have as standard work is that a second form of patient identification being provided so that we can confirm right patient. In our last failure mode, from a looking at it from the most prevalent of what we found during this FMEA, is the incorrect MRN medical record number being entered into our point of sale selling system. So this is really important, very easy. I believe our MRN numbers at Kaiser Permanente are about 12 numbers. So very easy for someone to transpose two numbers, maybe make an omission, do a number twice, a lot of ways that this can be incorrect and have the incorrect MRN placed into the system. For this particular FMEA, some actions taken, and I want to call your attention to the graphic on the right. So I'm assuming most of you are familiar with the ISMP hierarchy of effectiveness of controls as it relates to risk reduction strategies. So this is something that I look at and present with pretty much anything I do from a med safety perspective of how are we identifying these higher leverage error reduction strategies to mitigate risk. And then, of course, layering any of the lower risk mitigation strategies with higher leverage risk mitigation strategies, because we know low leverage strategies are not reliable on their own. But some of the actions that were taken for this particular FMEA, an enhancement request was submitted for electronic patient identification. And what I want to call out about this one and then the next one is that these align with the ISMP 2023-2024 Targeted Medication Safety Best Practices for Community Pharmacy #1. So we really wanted to use that as leverage with our Treasury team, which is who funded this particular initiative at Kaiser Permanente, so that we could say that we are making enhancement requests that are aligned with ISMP and what they recommend are best practices for community hospitals, or I'm sorry, community pharmacies. So the first was around an enhancement related to electronic patient identification, so being able to scan that in. The second is an enhancement request to require user credentials when an incorrect MRN is entered or a prescription scanning alert triggers. So making sure that we require a pharmacist to do that override. So this requires user credentials to acknowledge an incorrect prescription has been removed from the selling error, so we've taken it away. It includes alert data capture and reporting functionality so that in the event that an error still happens, we have the ability to go back and understand what happened so that we can help remediate that type of behavior from staff. We have put together, and this is actually, it says development, but it's been completed now, a national point of sale best practices SOP or standard operating procedure, and integration of safety steps and best practices into our training modules, making sure that we highlight that as we are training our staff so that they understand the safety implications. So the electronic patient identity validation intake, and this is in progress right now. I'm pretty positive this is going to be released. Right now, when I'm doing this presentation, we're in Q1 of 2024, and this will be delivered for us next quarter, so that's exciting. But what this will do, it will provide system support for users to accurately confirm patient identity, again, in alignment with the ISMP targeted best practice for community pharmacy. Currently, the systems do not include functionality to electronically validate patient identity, and so that's relying on the user to manually verify, which of course introduces human error into the process. The XStore POS system, that's our tool that we are using, needs to include functionality that requires the user to electronically validate patient identity to prevent wrong medication from being sold to the patient. And the functionality should be developed, including usability testing to ensure the enhancement is achieving the desired outcome with minimal impact to workflow. So this is part of what we provided to our IT team in saying, this is the problem that we're trying to solve. This is why we feel that this is a problem that needs to be solved. Of course, bringing in again the ISMP targeted best practices for community pharmacy as supporting literature, and then said, you tell us how you can make the system work for us. That's the model that we have in IT at Kaiser Permanente, where we work in concert with our IT partners to say, here's the problem that we as the business are trying to solve. You tell us how we can make this work within our system. So that's what we did. And like I said, I'm very excited in the next couple of months, we're going to actually see an enhancement come into our point of sale system so that we don't have these errors happen, hopefully in the future. So this is a slide that just shows what this user credential acknowledgement intake looks like. So current state, you can see not really a whole lot there alerting, but there's going to be more information that's provided in future state that's also going to require the user, which will be required to be a pharmacist, to type in their credentials so that we can make sure that there's been a pharmacist's eyes on the script to hopefully eliminate wrong patient errors. Here are a couple of examples of training and safety highlights that we provided in communications that have gone out to the field around this. So just calling out again how important it is to continuously educate our team members around safety. We also try to tie it back into high reliability so that we can really start to change the mindset of everyone in the outpatient space around medication safety and how safety is everyone's responsibility. The next case study is one that I guarantee, excuse me, that I guarantee everyone is very familiar with. This is in relation to the Vanderbilt error that happened several years ago, but this transition to the 5-letter minimum requirement and automated dispensing cabinet. So this is functionality that we still have not gone live with at Kaiser Permanente, even though it's coming this year in 2024. We needed to wait. until we got a software update from the vendor. But this is one that most organizations I anticipate are working towards and working through, as if you have not been able to implement this yet. But I will go through our process of FMEA around this in preparation for this change that will happen later this year. So an overview of what this particular initiative is. So this is an ISMP best practice recommendation. Is the required entry of a minimum of the first 5 letters of the drug name unless the drug name has less than 5 letters. So hoping to avoid choosing the wrong medication by requiring more letters to be typed in. Current state at Kaiser Permanente is that our ADC currently requires the first 3 letters of the drug name when overriding the medication. For future state, we just had to wait for the vendor to have the software ready, and we'll be implementing a little bit later this year. But we know that this functionality to expand to the 5 letters is coming this year, and so we wanted to proactively identify any risk that may result. So of course, FMEA being a great proactive risk identification tool, we felt like FMEA would be a great tool to use to help identify any issues that may come up, any unintended consequences. And this was also a recommendation of ISMP. They actually recommended in one of their newsletters that for organizations that were undergoing this change, that you should do an FMEA to make sure that you identify any issues that may come up. So the FMEA work group, they completed steps 3 through 5 on the FMEA steps here below. So here's yet another example of a way to conduct an FMEA. This one has 7 steps, but you can see they're all very, very similar. But doing a modified approach to meet the needs of your organization, I just want to call out that that is completely acceptable and okay. And you're going to see where we made some changes and did things a little bit differently with this particular one, which is why I wanted to give it as an example to show that really, so long as you follow the basic tenets of an FMEA process, you're going to get results and the information that you need to make substantial and sustainable changes that will enhance safety for your organization. But for this particular one, what they did do is describe the process, identify what could go wrong, and then pick what problems to work on eliminating. Now, because this has not gone live yet, we do not have any information in regards to any actions that we're going to take, have they been successful or not. So what we will do is after we go live with this functionality, we'll wait a few months and then go back and see if the interventions and changes that we made are actually resulting in enhanced safety. And if not, then we'll work through that again. And I would like to say that about the last case example I gave as well, the one with the transition from the point of sale to CPX for outpatient pharmacies. We just completed the install for that for all of our close to 400 retail pharmacy stores about a month ago at the time of this recording. And so we know we need to give some time for things to work. The enhancement requests are ones that are coming in 2024. So we have to give all of that time to work and see if from there we need to make any types of modifications. So like I talked about with the last case example, process mapping and determining the steps involved, really important. And so with this one, because this is a future process, we really honed in on those 2 pieces of this particular process of where things are going to be different once we go to the 5-character minimum requirement. So as we were determining the potential failure modes with this particular initiative, we focused only on the failure modes affecting the 2 future processes. So again, narrowing that scope, being really clear about what type of issues that we're trying to prevent. It's really around, once this change goes into effect, what are going to be some of those potential failure modes that could happen? So a couple that we identified that are on this slide. So first, the user sees the search bar and types in 5 characters of the desired medication unless the drug name is less than 5 letters. So what could go wrong with that? That's what the functionality is going to be. So what within that could go wrong? And I won't read all of these to you, but here's a list of the different failure modes that the team identified. It could be things such as the user types in a drug name that has multiple formulations, so the list still remains large. So what that means is maybe the 5 characters doesn't really help. So that's what we're trying to avoid, is picking the wrong medication by requiring more letters. But if it's one that has multiple formulations, there still could be a large list, so an error could still occur. A user doesn't realize a space, a dash, a slash, a symbol are characters, so that could also be problematic. Then another potential failure mode, any medication, this is the second bullet, any medication names with the same first 5 characters are displayed. So what could go wrong there? So a user may still select the wrong drug based on the available options. So a great example here is if you type in hydro, that could be hydrochlorothiazide or it could be hydromorphone. So it's not a perfect solution, but it certainly will help move us in the right direction from 3 to 5. But these are still some of the failure modes that could occur regardless. So as the team moved into risk prioritization, so the purpose here was to focus on problems that we think will happen frequently or have a significant impact on patient safety. So a reminder from the last slide deck that RPN, risk priority number, the higher the score, the riskier the process. So that's what you're going to want to target. Most of your interventions are ones around that higher RPN. That being said, I do want to call out, and I should have said this with our previous slide deck, is that there are multiple instances where maybe you'll see something that has a lower RPN, but it's low-hanging fruit. It's easy to implement. There's no reason you should not pursue that. I have absolutely pursued initiatives that have an RPN less than 100. 1,000 is the max, because if you take 10, 10, and 10, that's 1,000 as a max. So you can kind of think about an RPN from that perspective. But if it's low-hanging fruit, it's easy enough to implement. I have typically gone ahead and done that. But of course, also thinking through the perspective of the higher the score, the riskier the process, and I want to focus there as well. So it's a balancing act, but just wanted to call that out. So the selection of failure is primarily based on the 3 factors: the severity, the occurrence, and detection. Again, that's what's going to make up your RPN, your risk priority number. And what this work group did, they discussed the potential causes and effects of each failure mode, and they clearly outlined the outcomes and aid in risk prioritization. And then they focus on the first 4 failure modes ranked in order from highest to lowest, which I'll go through. So here are the results, and I know you're going to have these slides, so I won't go into a ton of detail here, but want to call out with this particular one. So this is where the user sees the search bar and types in 5 characters of a desired medication and the different failure modes that could exist. So we talked about some of these already, like the user types in the drug name that has multiple formulations, so your list is still large. With this particular one, potential failure effects, the user chooses the wrong med. That could absolutely be a result. There's difficulty in finding the correct med, delay in administration. And so the severity, and they did a scale of 1 to 5. Again, totally up to your team as to how you want to do it. I typically like to use 1 to 5, but they chose, I'm sorry, 1 to 10, but they chose 1 to 5. The average score that they took from everybody who was participating in the FMEA was around 3.2. But the potential failure causes, 1 could be that the list is too large with many options to choose from. 2 could be similar drug names, and 3 is same drug but different formulation and route. Occurrence, they gave a 3.5 with an RPN of 11.2. So you can see on this particular slide, as it relates to this particular process step of using the search bar and typing in 5 characters, the one that scored the highest from an RPN perspective is around having multiple formulations and the list being still too large. At the top, this is the process step of the, actually this is still the same one. So you can see there's still more potential failure modes. And this, I think, helps highlight just how big this can get. You can see there are potential failure effects or potential failure modes that are extensive. There are a lot of things that can go wrong with this. And so again, I like to emphasize how important I think it is to give your team the time and the space to think through this comprehensively. So don't rush the team, would be some of my advice. At the very bottom in the white, so this is the process step of any medications with the same first 5 characters are displayed, and goes through the different failure modes there, and you can see actually a higher RPN of 15.1 that was identified through that process. The top 4, as the team went through this exercise, The first being user may still select the wrong drug based on available options. This is that concept of maybe typing in hydro, you get hydromorphone, hydrochlorothiazide. That came out with an RPN of 15.1. The second is the user types in drug names that have multiple formulations, and so your list is still large. And so maybe you choose the wrong one that way too. Third, based on the RPN, is that the user does not know what to type since there are multiple names for a drug, such as lipid versus fat, ferrous versus iron sulfate. I can certainly see where that one would be problematic. And then the last one that scored out in the top four, the user types 3 characters, but type 5-character message disappears. And so then they think that the medication is not loaded in Pyxis. So going back to normal state and not realizing that we have to have 5 and then thinking that it's not stored in the Pyxis machine or the ADC. So the team further looked at these failure modes and broke them down by the potential failure mode and then looked for potential solutions. So again, don't want to go through all these in high detail, but like I said before, the IS&P hierarchy of controls as it relates to risk mitigation strategies, we really at Kaiser Permanente take this seriously of how do we layer on our solutions. We really spend a lot of time trying to identify medium and high leverage error reduction strategies because we know that using a lower level strategy is not going to be effective on its own. Of course, we have to have education. Of course, we have to have policies and SOPs and things like that. But we really need to move into those systems solutions so that we make it hard to do the wrong thing and easy to do the right thing. So how do our systems, our tools direct our staff to do the right thing? So that's why you'll see in these subsequent slides that we break out our solutions by high, medium, and low so that we're very clear how we are choosing to mitigate risk and being deliberate with that. So this is failure mode 2, user types in the drug name that has multiple formulations and the list remains large still with that. This was an RPN of 11.2. Some potential solutions. So with high leverage, for example, you can tag medications by weight if it's weight-based. If weight is lower than the threshold, you can incorporate a forcing function. So thinking through how we can make our technology work for us. Some examples of success with this could be with the standardization of Pyxis, and that's the ADC that we use at Kaiser Permanente. Looked at medication utilization over a year, ran a report to see the number of times each dose was used, and were able to remove low or non-utilized doses and strengths to minimize different available dosages for certain medications. So doing that maintenance on your ADCs to take things out that aren't being utilized to help eliminate error is a great way of being able to use your data in your ADC to your advantage. One thing we did call out is that challenges could include shortages. So you guys, I am sure, have to worry about drug shortages. That's something that I spend a good bit of time with at my current organization, is overseeing the medication shortages for the organization as an enterprise. And there are going to be times when there's just nothing we can do. With what's available, what we're able to procure, things like that. So that's why it makes identification of these strategies to mitigate risk even more important, is that we know that we're going to be in situations where we are going to have our hands tied behind our back, and we need to have the systems and the tools in place to support safety as much as possible. Failure mode 3, this is the failure mode where the user does not know what to type since there are multiple names for a drug. Again, this is something like lipid versus fat. Unfortunately, we weren't able to identify any high leverage risk reduction strategies, but we were able to identify some medium and low. And then the last one, user types 3 characters, but type 5-character message disappears and thinks that the med is not loaded in Pyxis. A high leverage strategy that was identified here is to program the Pyxis so type 5-character message does not disappear until the user satisfies the requirements. So I would hope that would be a relatively easy implementation. That would be more high leverage. So in assessment of this particular FMEA, it did provide valuable information to optimize implementation of the Pyxis 5-character requirement. Many of the identified failure modes are similar in overlap, so you probably saw that. That's why I didn't spend a whole lot of time going to each one of those, because they are very similar in nature. And based on risk prioritization, the highest ranked failure modes were the wrong drug selection, drug naming, and system concerns. And then the potential solutions that were proposed by the group will certainly assist with mitigating the failure modes identified. And we will work through that as we move forward with getting closer to implementation of this technology. So with the recommendations, again, I love this IS&P graphic. I put this in a good bit of my slides so that I can continue to educate people on the importance of this hierarchy of controls as it relates to risk reduction strategies, and emphasizing how important it is that we move from human reliability to system reliability. With human reliability, education. I think almost always with whatever initiative that you are working on, you're going to have to educate, or maybe even create a policy or an SOP. There's, like I said before, absolutely nothing wrong with that, but it must be layered with medium and high leverage error reduction strategies. So again, these low human reliability. Humans are fallible, we're going to make mistakes, so that's why we have to do the layering. But with this particular one around education, we just want to make sure that everybody understands what this functionality is and what we're doing with it. And what we will train and provide is just update on this is what's happening. We're going from 3 to 5 characters. We're going to list the contents in Pyxis machines on a regular cadence and keep that visible in the medroom so that there's kind of a quick reference for the nurse if they need to reference that. And remind users with a note on the Pyxis machine to type 5 characters. So I don't know how long we'll keep that in place, but for a short amount of time so that people don't forget. Moving now into medium leverage error reduction strategies. So this is where we're relying less on the human, more on the system, but kind of in the middle. So safety science and design, making it easy to do the right thing. Dual nurse sign-off for overrides, implementing that. Standardize the types of medications loaded into the Pyxis. So that's where doing that assessment work to understand what's being utilized versus not is important. Program the Pyxis to recognize multiple names for drugs. So doing some back work on the pharmacy side, especially for drugs that may have different common names. And make errors visible. Implement a CDC, a clinical data category alert that requires the user to act prior to removing high alert medications, things like that. Now we're moving into reliability on the systems. Now we're at the top of the graphic here. This is where we've got the most effective risk reduction strategies, but they are the hardest to implement. But this is where we're relying upon the system. So increase the number of profile Pyxis machines. This is something we think is important, just as a safety initiative in general, not necessarily just attributed to this particular work, but how important it is to make sure that our Pyxis, our ADCs are profiled to have that level of oversight. Incorporate a forcing function by weight for weight-based meds, and program Pyxis so that the type 5 characters message does not disappear. So moving into our self-assessment questions, in the ADC example, which FMEA steps did the team complete? A, describe the process. B, identify what could go wrong during each step of the process. C, pick which problems to work on eliminating. D, A and B, or E, all of the above. Answer is E, all of the above. So in conclusion, using FMEA is effective in understanding risks of new technology or functionality when introduced into the organization. And using FMEA allows teams to proactively address and reduce risks of implementation of new technology or functionalities. Here are my references. And thank you so much for your time today.